Good morning and welcome to the Insurance and Pharmaceutical Subcommittee of the House Health and Government Operations Committee. This is the group that works through bills. And welcome to the, okay, we're getting feedback here.
No, sorry, it automatically opens YouTube, which I always have to turn it off.
Sorry. This is the group that works through bills and gets them in shape to take and makes a recommendation to the whole committee. We are discussing two bills today. I do not anticipate voting on these bills today, but I want to have a discussion about them so that perhaps, we know, what is the best way forward to address the issues that the bills were created for. So the first bill is House Bill 142. And Lisa, would you remind us what House Bill 142, I'll read the name, Health Insurance Coverage of In Vitro Fertilization Revisions.
Sure. House Bill 142 expands the coverage requirements for IVF by prohibiting carriers from excluding expenses arising from IVF, including outpatient services, pre or post IVF procedures, pre-implantation, genetic testing, and medications. The bill also prohibits carriers from denying coverage of IVF because the policyholder or subscriber or dependent spouse is a genetic carrier. The bill requires coverage if a healthcare provider makes specified determinations about a patient's fertility and mental health, and the bill repeals the religious exemption for the coverage of IVF.
All right. Delegate Lamprey, welcome back. You have any further thoughts, information, other than what we talked about last week?
I think, we're ultimately, we've had some conversations. I won't say we've made some definite decisions, but I think that we're more so leaning towards narrowing the bill so that the intent, the true intent behind the bill is to expand coverage for genetic carriers. And I think we want to focus on that group with this bill and work to most likely remove the religious component of the bill, while we still believe wholeheartedly that individuals who use a provider that's a religious institute that has religious affiliation or may work for a religious institution, we want to make sure they have full access to all the healthcare they deserve. But I think that ultimately that's something that we can tackle another day. We still haven't heard from we haven't had a chance to speak with the Attorney General's office on those matters either. But I think we're pretty much ready to move forward with removing those parts of the bill and just proceeding with just the genetic carrier piece.
Thank you, Delegate. Thanks for following up on some of the questions that we had. And those who were attending the subcommittee meeting last week, remember that there were a number of questions on this bill, not the least of which was the religious exemption, which I now hear as an openness to removing that piece. But there were some questions about this as an extension of a mandate, what the financial impact would be. And I'm going to look to Executive Director of the Maryland Health Care Commission, Ben Steffen, who's I asked to attend today. Mr. Steffen, can you tell us how typically we make assessments around how much, what the impact on premiums might be when we either add a mandate or expand a mandate? Ben, I think you're on mute.
Thank you, Delegate Cullison. So the Healthcare Commission has two authorities regarding the assessment of mandates. The first one is that we are called on to provide a actuarial assessment of mandates that's failed in the previous legislative session. That seems kind of odd, but the rationale was that back in the day, back in the pre-ACA days when mandates were very commonly considered by the legislature. It commonly took 2 years for them to pass, one to sort of orient the legislature to the issue. It would fail, and then in the interim, the Healthcare Commission would employ an actuarial firm to look at the financial cost as well as societal, social impact of the mandate, impact on patients, and submit that report to the legislature in the following session. The legislature would have additional information to consider and oftentimes would adopt the mandate in the second year. This has become less common with the ACA, passage of the ACA. There have not been as many mandates. We've done several studies, most recent on digital imaging for mammographies, tomosynthesis. And that was actually implemented in Maryland law a couple of years ago. Should this mandate request not pass, we would consider whether we would employ an actuarial firm to provide an estimate and look at the impact on the overall health insurance benefits. I'd note that today, the in vitro mandate, this is not covered in the small group market. I noted in the bill that language was still there as well. And that is because it is not part of essential health benefits for a small group market, and the state would have to pay for that benefit if it chose to impose that now. We also do a cumulative impact of all benefits every 4 years, and the commission typically says that any individual mandate is not by itself impactful, but the cumulative impact of all mandates is more substantial. The exception is always in vitro, which is more expensive than most of the 20 or so odd mandates that are in Maryland law today.
Thank you, Ben. Is legislation necessary for you to move forward with an actuarial study, or can we just request it?
There's no legislation required. If this particular bill, House Bill 142 passes, we wouldn't do it. If it did not pass, we would simply a letter requesting it would be all that's necessary.
Okay, great. Thank you. Any thoughts or comments from committee members, subcommittee members? Delegate Krebs.
Thank you. Ben, explain to me again, I wrote this down. So currently in the small group market, you're saying we do not have the in vitro mandate, the general in vitro mandate. Is that accurate?
That's correct.
So if we added this, would it only be this exception in there, or would it bring all of it into it?
That's a good question. I mean, it wouldn't make sense unless the entire in vitro mandate was incorporated into the small group market mandated benefits, in my opinion, and that would then trigger the ACA requirement that the state fund that particular.
Right. And I think so. Unfortunately, this little thing is way bigger because it's not in the current mandates. But I would ask, first of all, we need to look at it in that broader picture, because it seems silly to have one little carve out for this and not have everything else. But if we do the letter of request next year, I would ask, and I thank Delegate Ampray for taking care of the two issues that we had issue with, the removing of the language on page 5 and then narrowly tailoring this. So if we ask for this to be looked at, can we do that with those agreements in place that we're going to narrowly look at this first? Instead of looking at the bill the way it is today, it's just a question for the subcommittee chair. But I think, unfortunately, the bigger picture here is the impact on the entire in vitro mandate that is not really a mandate right now, according to the ACA. So and Delegate Ampray, it's a confusing issue about how we adopted these things in the ACA. But I think we need to figure that out in our committee here, subcommittee. Thank you.
Thank you, Delegate Krebs. I'm going to call on Delegate Kelly, and then I'm going to sort of try to move us along on this. Delegate Kelly.
Thank you, Chairman Collison. And I just want to say that I think that there's so much tremendous merit in this bill. I was really moved and concerned by I think it was Esposito's testimony. I think that the crux of the problem that we definitely need to solve for is figuring out how to make sure that genetic carriers have access to in vitro the same way we did when we did. I mean, many of the committee members remember us modifying this mandate after we passed same-sex marriage to ensure that lesbian couples had access to in vitro. So I think finding a way to do this is, for me, a moral imperative. It makes sense. I think it will be a very, very narrow but incredibly important equity sort of based expansion, if you want to call it an expansion of this mandate. I don't think we can responsibly choose to do it without hearing back from the Healthcare Commission. So I think that it's important that we take some time to figure out. I mean, that the small group market piece is obviously concerning. We need to make sure to cross our T's, dot our I's, make sure we understand what the current plans look like and what this potential cost might be. I think personally it's the right thing to figure out how to do, but I've worked on a lot of insurance mandates over my 12 years here, and figuring out how to do it right takes time and expertise. So those are my thoughts on this. It is, Delegate Ampry is really onto something here. The witness he brought to testify is right, and we need to figure out how to solve for this problem the best way that experts who understand insurance law and mandates can help us figure out how to solve for it with the least impact on the rest of the plans. That's my thoughts.
Thank you very much, Delegate Kelly. I appreciate that, and I agree with you 1000%. Mr. Celentano, can I ask you a question as the representative of the League of Insurers? Would you all be willing to work with Delegate Ampry during the interim to sort of, more clearly define how we achieve the goal that we're trying to achieve here, as Delegate Kelly so eloquently stated it?
Absolutely. I'm not going to try to repackage Delegate Kelly's wonderful thoughts. But yes, the answer is yes. We'd be more than willing to work in the interim.
Okay, then given that, what I'm going to ask the committee is if you would support holding this bill, and let's give until, essentially holding it until next session, but give Delegate Ampry, the insurance carriers, and the MHCC time to look at the issues in a way that will help us move the intent of the bill forward, and address any issues that we have. Any thoughts from the committee? I've got a thumbs up from Delegate Krebs.
Sounds good.
Okay, I'm going to let Ms. Esposito say something, and then I think we'll move on from here.
Yeah, I just wanted to request, in the meantime, can there be something that's given out to doctors and patients like me that know that they can appeal? Because that's one of my biggest concerns, is that I happen to go to a clinic that was used to dealing with these issues and taking patients like me. They had the specialty, but for new doctors and patients that are new, finding out now that they are carriers of deadly diseases, a lot of them give up as soon as they receive that denial, even though they're eligible for coverage, but they don't have necessarily the tools to appeal and get the coverage that they need, especially for genetic testing. So I don't know if there's any way that there could be some type of notice from MDH or something, just saying, there is a process available, and this is the route.
I'm going to ask Dave Cooney from MIA. Dave, I'm going to put you on the spot here. How do you know currently, is there a way that folks are being notified of this ability to appeal?
So every explanation of benefits that's sent out, whether there's a coverage decision or an adverse decision, that does have, the carriers are required to provide notice that there's a right first for an internal appeal with the company, and then, they're still dissatisfied to file a complaint with the commissioner. So it's already required by law and it's there. Difficult making consumers aware of that. But yes, it is currently required and is currently provided.
Okay, so I mean, I understand that's probably not the level of awareness that that Ms. Esposito is asking for, but there is something there currently that says folks can appeal. But as we work through the bill, perhaps there's a way for us to figure out what the best method for providing that information is going forward. Delegate Kelly? Oh, you're on mute.
I'm on mute. Just wanted to raise that, and this is something because we also did a tweak to this mandate for unmarried individuals. I remember I did that a couple years ago, that we may be able to partner with ACOG, with Maryland ACOG, and have the provider associations voluntarily share information that way. So I can certainly reach out to them and make sure that they're updating their members who are specialists in this field so that they have that information.
Okay, that would be terrific. Thank you. Okay, so first of all, I want to thank Delegate Ampry. I want to thank Ms. Esposito for coming and bringing us this bill and raising this really important issue for us. I believe that with the work that everyone's going to do over the interim, we'll come back ready to work on this next January. So any last words or comments on 142? Okay, thank you all very much. We're going to move to House Bill 247, Insurance Medicaid Supplement Policy Plans, Open Enrollment Period Following Birthday. Lisa, want to tell us what it does?
Sure. House Bill 247 requires a carrier that sells Medicare supplement policies to provide an enrolled individual the opportunity to switch to a Medicare supplement policy with equal or lesser benefits within 30 days following the individual's birthday. A carrier is prohibited from denying or conditioning a new policy, discriminating in the pricing of the policy, or denying, reducing, or conditioning coverage because of the health status, claims experience, receipt of health care, or medical condition of the individual. A carrier must notify an insured of their right to switch plans at least 30 days, but no more than 60 days before the insured's birthday. I distributed a reprint and some amendments. The amendments remove the word plan when referring to Medicare supplement policies. They make provisions regarding pre-existing conditions the same for the initial enrollment in a Medicare supplement policy and during the special enrollment period for birthdays, and provide that the special enrollment period for birthdays applies to individuals enrolled in a Medicare supplement policy who have birthdays on or after July 1st, 2023. The amendments also authorize the insurance commissioner to adopt regulations defined equal to or less than for purposes of determining which Medicare supplement policies an individual can switch to during the special enrollment period, and changes the effective date of the bill to January 1st, 2023.
Thank you, Lisa. Is Delegate Resnick here? I don't see him. Okay. Then is there anyone who wants to speak on behalf of 247, House Bill 247 at this time before the committee starts discussing? Okay. I guess I'm going to go. I saw the insurance commissioner. Is she still here? There she is. Commissioner, did you want to tell us a little bit about the amendments that MIA is recommending?
Well, in this one, I'm going to defer to David and Brad because I think that will be the most succinct way.
Okay. But in the meantime, I want to welcome you to the subcommittee. Sorry, I didn't do that first. Thanks for coming.
No worries.
You'll be able to check up on David and Brad while you're here. So thank you. David, you want to talk to us about the amendments?
Sure. When we were just looking at the bill as drafted, from a technical perspective, we just identified a couple issues that for consistency with other statutes and to better enable us to enforce it, we had these few recommendations here. The first one that Lisa mentioned, just removing the word plan from any of the places where it appeared. Typically, the word plan is used when you're talking about Medicare supplement policy plan. And if you're talking about one of the specific letter designations like A, B, C, D, that's the only time you use the word plan in there. If you're just talking about the policy in general, you just need to say policy. And just by introducing this new term where frequently these revisions said Medicare supplement policy plan when they weren't identifying a specific lettered plan, it just seemed to create an ambiguity that this is some new term that's somehow different from all the other references in the insurance article to Medicare supplement policy. So it was a real technical revision we suggested there. The other issue was with the pre-existing condition limitation. There is a cross-reference earlier in the bill when it's talking about the initial open enrollment period that makes it clear that although you can't do underwriting and so on during that, carriers are still allowed to apply a 6-month pre-existing condition limitation in that situation. The way the bill was originally drafted for this new birthday rule, that same cross-reference wasn't there. So it was treating the birthday rule different than the initial open enrollment period. And it would actually allow certain consumers who were kind of aware of this loophole, they could get around a pre-existing condition by enrolling in one plan by their first birthday, then immediately switching to a different plan, and the pre-ex would have to be immediately waived, when that's not the way it's treated for the initial open enrollment period. So just to put everybody on the same level playing field, we suggested adding a cross-reference to make it clear that for that birthday rule, it's the same situation. The carriers can apply a 6-month pre-existing condition limitation, but it has to be reduced by any kind of continuous coverage you've had up to that point. And then the third issue is just this special enrollment period allows consumers to switch to a plan that has equal or lesser benefits. And the statute has a deemer clause that essentially says a plan is deemed to have equal or lesser benefits if certain conditions are satisfied. The issue is it's kind of a little bit convoluted the way it works. And if you go through and compare plan to plan, it actually results in certain situations with that deemer clause where a plan clearly has greater benefits, but it's deemed to have lesser benefits, or vice versa. So our suggestion was the commissioner, we could easily adopt regulations that actually give a crosswalk for each lettered plan and say for plan, for plan D, these other plans have equal or lesser benefits. For plan C, these other benefits these other plans have equal or lesser benefits. You can't really do that in statute, but if you change the deemer clause and just instead authorize the commissioner to adopt those regulations, we could really make it clear which plans have equal or lesser benefits and just kind of clear up the issue. So those were our 3 recommendations, and I'm happy to discuss any of them further if there's any questions.
Thank you, David. I appreciate it. Ms. Lively, I see your hand, but Delegate Resnick is here, so I'm going to defer to Delegate Resnick first to speak to the bill, and then I will come back to you. Delegate. If you want to speak, Delegate Resnick. Okay. I'm not hearing him. So Ms. Lively, I'm going to go to you, please. Oh, wait a minute. He just came back in. Delegate Resnick, are you there now?
Yes, I apologize. For whatever reason, she was not, the Zoom was not letting me just to unmute or turn on my camera. So I apologize. And I apologize for being late. I was not aware that this was happening right now. So just very, very quickly, I only heard half of what Mr. Cooney said, but I am aware that there might be a situation given the 6-month initial open enrollment, and then immediately 6 months later there's a change. So however we want to adjust the language to accommodate for that first year, I'm open to having that discussion.
Okay. Then I'm going to go to Ms. Lively.
Thank you, Chairman Cullison. Let me turn my video on. There we go.
Thank you.
Hello, Chairman Cullison, members of the committee. My name is Elizabeth Lively.
I am Eastern Region Advocacy Director for Dialysis Patient Citizens. I want to thank you for the opportunity today to make a few comments about this bill that Delegate Resnick has had introduced for the past several years, as it will really help our membership, which consists solely of end-stage renal disease patients. My organization, Dialysis Patient Citizens, we're based in Washington, D.C. We're a national nonprofit patient advocacy organization. Our CEO, Harant Jamgoshen, is a Maryland resident. And one of our board members, who is also a Maryland resident, Maria Robinson, she submitted a letter in support of the bill to the full committee at the end of January. I don't know if anybody has seen her letter or not. Maria Robinson describes a very unique situation and a really good reason why this bill is so needed for dialysis patients. Often dialysis is so debilitating that people can't work. And in her situation, she was able to get a position through at a senior center in her area through a Maryland Department of Education 55 plus program. And she was able to be covered by Medicaid, which would take care of her out-of-pocket reimbursement for dialysis and her other medical needs while she was employed. However, during the pandemic, she lost her employment and needed to have supplemental insurance coverage. Fortunately, Maryland does offer one plan to individuals who have not yet achieved the age of 65, and she was able to do that. However, it was medically underwritten because there was no special open enrollment period for her. So that was an issue for her. And it highlights how this bill really can help a lot of individuals in the state of Maryland. And it would be a wonderful thing if Maryland would join the 9 other states in our country who already have similar legislation in place. With that, thank you very much.
Thank you. Thanks for coming and speaking today. Kathy Grayson.
Good morning, Madam Chair. Thank you so much. I actually just have a technical question for the MIA. Really appreciate their amendments and are looking at those internally. On the third piece where the MIA could promulgate regulations to determine what equal or lesser value is, I was just curious if you know, is that how the other states do this with the birthday rule? Or do they prescribe in the statute what equal or lesser benefits are? I'm just trying to understand the genesis of that.
Actually not familiar what how other states have handled this. I'm not even sure if all the other states have the equal or lesser clause in there, or if it's just you can go to any plan on your birthday. So I'm not actually 100% sure on that. Well, the approach we took is we just looked as the statute was drafted. It had a deemer clause in there, and it said it's deemed to be equal or lesser if these 2 criteria are met. And when we kind of looked at that and mapped it out to the different plans, we just saw that resulted in some situations where they're not really equal or lesser. And that was the impetus for our comments, but I'm actually not aware what other states are doing.
Delegate Resnick, do you know any more about the other states?
I'm sorry, in what way? Whether or not they allow for equal or lesser?
Or if they've defined equal or lesser?
I don't know the answer to that question. I'm sorry. We can look it up.
We can find, yeah. So I'm gonna take, let's see if we did Kathy. Kim Robinson.
Good morning, Delegate Cullison. I'm sorry I was delayed joining this morning, and thank you for the opportunity. I'm sitting as a member of AHIP, and I know AHIP did testify on the bill. To the question in front of you, thank you for sharing that there were some MIA amendments and hearing what they are. I've already sent a note to my team who does this in the small number of states that do have a similar law. So at least we would have the answer as to how other states are doing it. My understanding is that language is common in the other states' laws. So clearly those states have figured out how they are dealing with what that equal or lesser language looks like. And so maybe they'll be instructive for the MIA and for this committee. Because should the committee choose to move the bill forward, I think it would probably be easier for carriers who are nationwide and implementing the law everywhere if that approach is consistent.
Okay. Thank you for that.
So if we have a few days to get back would be great.
And I think that we're going to accommodate that. I'd like to propose to the subcommittee that we hold this bill until next week. We will vote on it next Tuesday. We'll vote on the amendments then too, so that if there needs to be some adjustments to the amendments after the carriers and look at it and look at bills in other states. But we'll come back to it first thing next week. Is that agreeable? Is anybody on the committee not in agreement with that? Okay. Delegate Bandari.
Yeah, I'm in agreement, but if I may, Madam Chair, I have a quick question to David.
Of course, go ahead.
Yeah, David, is this bill strike 1 through 11 and substitute the language you explained. And there is on page 2, line 6, it says coverage for 100% of the Medicare Part A deductible. When we replace the language, still it served the purpose, right? They're 100% coverage. I mean, they will have 100% coverage, correct?
Yes, that language just identifies and covers 100% of the Part A deductible, whether or not it's treated as having equal or lesser value. So that language is not changing the benefits that an individual has under their plan. It was just to define if a plan has that particular benefit and the other plan does or does not, which one is considered to have equal or lesser benefits.
Thank you.
Does that help? Okay. Is there anyone else who has a question or a comment about the bill? Then I would ask that carriers check with your folks in terms of if these amendments are, if there's something that we need to address in them. And in the meantime, we'll also be looking at the other laws to see how they address the equal or lesser benefit issue. Any other thoughts? Then that and we will vote on this bill next week. So come back ready. Okay. That concludes the work of the subcommittee today. We will meet next Tuesday. I'm assuming it will be 11 o'clock, but I think we're going to be back on the floor next week. So please watch the website for closer to the starting time. All righty. Thank you all very much for your help and support today as we worked on these bills. See you all later.